hemorrhage with my moderator is my supervisor is Dr. Howell. So primary postpartum hemorrhage, it's one of the 5 causes of maternal mortality in both developed and underdeveloped countries or developing countries. It's been proven over the years that timely recognition and an availability of appropriate resources are very important in the management of primary postpartum hemorrhage.
Yeah, I think, yeah, the slides are changing now. So you can
this will be the outline of my presentation. So worldwide, it is the leading cause of maternal mortality, especially in the sub-Saharan African and then the Asians. It's been recorded as the leading because you have over 80,000 women who die from maternal mortality every year. And this is quite alarming. So that is why postpartum hemorrhage is something to be looked at and promptly managed. In Ghana, in 2018, it was declared as a national emergency because you had over 60% of maternal death being attributed to that fact. In Tamale Teaching Hospital, where I'm being trained, last year, we had a total of 14% of our maternal mortality being attributed to postpartum hemorrhage. And also in 2022, it was 3.5% of maternal death. So we'll look at the definition of maternal mortality. I have to say that the definition of maternal mortality has undergone a lot of changes over the year. Classically, it's been known as blood loss, that is in excess of 500 mils via spontaneous vaginal delivery, in excess of 1,000 mils via cesarean section. But this has come under a lot of criticisms because you can't really quantify. It's been known that quantification of the blood loss is usually underestimated to sometimes about 50%. So because of that, it is imperative that other ways of assessing the blood loss are used. So FIGO and then other obstetrics and gynecology organizations have come up with other definitions, such as any amount of blood loss which is sufficient enough to cause hemodynamic instability, which is sufficient enough to cause hemodynamic instability, and then also which would warrant blood transfusion. Also, it's been noted that sometimes when you look at a woman's hematocrit level while she was on admission before the delivery, if you have an hematocrit level rising for more than 10%, you can make that diagnosis. Also, it can be classified into major and minor, where you have the minor being amount of blood loss 500 to 1,000 mils, and then major more than 1,000 mils. So to classify it, it can be classified as primary and secondary, and we are going to look at the primary. The primary being blood loss in excess of 500, usually after delivery within 24 hours, and the secondary is from 24 hours to 6 weeks. Okay, so we'll look at the causes of primary postpartum hemorrhage, and it can be classified into the 40s, where we have PON, which causes more than 70% of primary postpartum hemorrhage. Atony, that is uterine atony, inability of the uterus to contract after delivery. It causes majority of the cases we have in PPH. And then we have trauma being the second leading cause. That's within 15 to 20%. Tissue, that's retained product, contributing to about 10%, and then less than 1% being thrombic. So under the uterine atony, anything that would cause overdistension of the uterus or stop the uterus's ability to contract would result in an atony being the cause. So for example, overdistension from polyhydramnios, from multifetal pregnancy, sometimes anything that can be in the uterus, for example, a previa, low-lying placenta, that would affect the normal uterine contraction, a placenta abruptio like Puvale uterus, which affects the uterus to contract, retain products. All those things can contribute to the uterus losing its tone and the ability to contract. If we look at the second T, which is trauma, we have delivery of big babies, anything that will cause trauma, for example, assisted vaginal delivery, instrumental delivery. Sometimes you have rupture of uterus from scarred uterus and from augmentation, syntocinon augmentation, and etc. Obstructed labor as well. Tissue being a cause, placenta accreta, so the accreta spectrum, and then accessory lobes of the placenta, which is usually retained. The least common cause is coagulopathy, and usually we have acquired and congenital. The very common ones under acquired would be the DIC, usually disseminated intravascular coagulopathy from placenta previa preeclampsia, and then sometimes when people are on anticoagulation therapy, and then amniotic fluid embolism, and some bleeding disorders. So physiologically, what happens is that with a woman, when the woman gets pregnant, during the pregnancy season to period to delivery, there's an increase in blood volume of between 45 to 60%. And that's about 1.2 to 1.5 liters of total blood volume. This is like the normal physiology of the uterus to make way for the excess blood that will be lost during delivery, so that the woman's system does not get compromised, even though there is blood loss. There's also a natural physiology of the uterus where the myometrium contracts. So it has an ability of contracting and retracting and making the myofibrils shorten. When they shorten, they compress on the vessels and then occlude them. This has a way of reducing the bleeding, usually from the placenta bed, which is avulsed during the detachment of the placenta. Also, there's a mechanical mechanism, that's the myotamponade of the uterine walls, anterior and posterior. They compress on each other, and by so doing, they help to make sure that the uterus is able to contract and be able to stop the bleeding. And clotting factors that are released at the placenta bed is also a natural inbuilt mechanism that ensure that there is no excessive bleeding after delivery. So the primary postpartum hemorrhage, how will a woman present with if she has primary postpartum hemorrhage? Commonly is profuse bleeding. However, I have to say that sometimes they may not present with profuse bleeding. For example, if they come with a uterine rupture, they may be trickling down blood, but they have hemoperitoneum. Sometimes if there is Puvale uterus where there's concealed bleeding, they may not be bleeding profusely. But one thing that is very obvious is signs and symptoms of blood loss, where you can see from a comprehensive physical examination, looking at her vital signs as well, whether she's pale or not, whether her pulse, whether it's weak and thready, whether the pulse is high. All those things can give you a sign that the woman is bleeding, of course, from the history that she just delivered. Also, a flabby uterus, a uterus that is filled with blood. Sometimes when you palpate the fundus, you have the uterus way high, subinvoluted above the umbilicus. It will give you a fair idea that she is bleeding, and then it's also due to atony. So how will you clinically assess a woman that has primary postpartum hemorrhage? First of all, you need to do your primary survey. Primary survey will involve checking her airway to see if she has aspirated. If there's any secretions, you suction them, and then her breathing. The breathing will include her respiratory rate, and you check her SpO2. If she may need oxygen supplementation, sometimes even though her SpO2 may be fine, but she may be using accessory muscles, and it's imperative, especially most of them are anemic. So you want to give oxygen to increase the oxygen carrying capacity of the cells that are there. And then circulation, you need to check for a capillary refill time. You need to check for her blood pressure and her pulse. All these would give you ideas as to what is really going on. Monitoring of vital signs, as I've already mentioned. There is what is called the shock index. It's one way that has been used over the years to be able to assess the amount of blood loss and the severity of the disease. So it is defined as the ratio of the heart rate over the systolic blood pressure. And it's a very good predictive value, because if we are going to just use the blood pressure and the pulse, ideally, it's been shown that if the blood that is lost is not usually up to 1,000 mils or more than 1,000 mils, there is really no significance improvement, or there is no significant change in the pulse and the pressure, because the body has its own cardiovascular response mechanism that's able to overcome the acute blood loss. So the shock index, like I already mentioned, it's usually, if it's greater than 0.9, it's associated with mortality. And then a standard obstetric shock index should be between 0.7 to 0.9. But in a non-obstetric woman, usually is between 0.5 to 0.7. So I think I already mentioned these ones. So this one too will help, especially those in the peripheries. If you have a shock index of greater than 0.9, it should be something that you should be thinking that the woman may need urgent transfer for blood transfusion and other refractory management. So there's a visual assessment of blood loss. We'll come to why now this is not really used a lot. But over the years, I'm sure some of us have assessed blood using this method. So it's quite, explanatory. So maybe if you get the slides, you look at it. But, okay, so let me just mention a few of them. So for example, if a woman stains her pad partially, the estimated blood loss can be like 50 mils, which is already here. If the pad is fully soaked, the sanitary pad that is fully soaked, the amount is like 100 mils. If you have a small soaked swab, it's like 60 mils. But if you have a swab that is like an abdominal towel, that's about 350 mils. And if you have a kidney dish that is fully soaked with blood, you can give an estimate of about 500 mils of blood. Once a woman has PPH and the blood spills on the bed and all over the floor, you can give an estimate of 2,000 mils. If it's only on the bed, you can give an estimate of 100 mils. And this is to add on to the assessment of the blood loss I already mentioned. So it can give you the ranges based on the ranges and the blood pressure and then the symptoms that it can come with. So over the years, there's what we call the bundle care. There's a way to manage PPH from different organizations all around the world, including WHO. And it's been a systematic approach of handling and managing PPH comprehensively. This is a mnemonic to help us to be able to remember what it entails. The first of all is, so the mnemonic is hemostasis, the hemostasis we know. And the H is, before I even go to the H, I have to mention that one main thing in management PPH is that, first of all, the principle is that do not panic. Because as soon as you panic, as soon as you're afraid, as soon as you start shivering, your judgment and everything is occluded. So first of all, you need to call for help. The help includes everybody in the team, includes midwives, includes anesthetists, it includes doctors, resident consultants. It includes anybody, even the lab people, anybody who may be involved in this care. So you need to call all of them and then assign meaningful roles to them. And then whilst you are calling for help, the H also stands for your hands. You should assign a role to somebody to put the hand on the uterus to massage the uterus for at least 1 minute, every 15 minutes. And then we have A, which is to assess. You need to assess the woman, like I said, check the primary survey, and then the assessment will also include resuscitation, where you pad 2 large bore cannulas and then start your IV resuscitation, 500 mils in 30 minutes. Then you give 1 liter in the next 1 hour and put her on some maintenance. So if she's in shock, you correct the shock. And the resuscitation will also include, of course, taking samples for grouping and cross-matching, clotting profile, other investigations that are relevant. And you need to establish the etiology, very important. Establish why she is bleeding. Concurrently, because uterine atony is the commonest cause, you can massage. Even the hands is massage. So you can see that it comes way ahead before you even establish that, because once you're able to massage the uterus and then the uterus is not well contracted, you'll be able to stop the bleeding. So you need to massage the uterus. And then the O stands for oxytocin infusion, which is usually giving at 10 international units in 500 mils of normal saline to be given in a space of 2 to 4 hours. And then the next is S. So whilst you are doing all these things, if the woman is still bleeding, you have to shift to theater. And in the process of going to theater, you can do a bimanual compression where you can insert your, under sterile conditions, you insert a fist, you make a fist into the vagina and the anterior fornix, and then you have your non-dominant hand on the abdomen to be able to create pressure in the posterior wall so that you can cause like a mechanical tamponade. Whilst on your way to theater, you can do that. You can also do apply pressure on the aortic area to also reduce the bleeding. And then anti-shock garment will come there later. So after shifting to theater, in theater, you can do this. That is more like a refractory PPH. I'll talk about them. So I'll talk about some of these things later. So there's tamponade, there's apply for a systemic pelvic devascularization, interventional radiology, and then subtotal hysterectomy. So this is motive. So this was actually, emotive. It was actually, it's quite a new way of managing PPH, which was came in last year, May 2023, from WHO researchers who sat down and noticed that the rate of mortality and morbidity of PPH has not seen any significant increase over the years, even though the bundle care, like I mentioned, the systematic care plan is being undertaken and all that. So this was a means to try to assess blood loss, because they realized that the visual assessment of blood loss has caused a lot of problems. It has brought about with underdiagnosing and subsequent management or delay in management of the PPH. So the main purpose of this is to detect the PPH early. So a drape, a collection drape, which is calibrated, is usually used, is put under the bed of the woman. And every blood that she loses is able to drain into this drape. And due to that, is able to assess the amount of blood loss. If the blood loss, and from the early detection, you can also, apart from assessing the blood loss, there is what we call the observation. So observation of the blood loss, of course, you need to also observe the vitals. So if you observe the vitals, the BP, the pulse, and then you measure the blood loss in the drape, and then you have about 300 mils of blood in the drape, and you have an abnormal observation, you can term it as PPH and start management. Or you have a blood loss of about 500 mils, and then even with a normal observation findings, you move ahead and start managing and following this protocol. The other thing about this emotive is that the plan is that now all these initiatives would be done concurrently. So compared to the initial initial bundle care plan by WHO, where you do each of the managements sequentially, this one is done collectively. So the M stands for massage. So you need to get somebody who will massage the uterus within 1 minute. This whole bundle is within a space of 15 minutes. So somebody will be assigned to massage the uterus. And then you give the syntocinon, which I've already mentioned. You give 10 international units in 500 mils of normal saline, or 20 in 1 liter to run slowly within 2 to 4 hours. And an IV tranexamic acid, 1 gram, can be given within a space of 30 minutes. And if the woman still bleeds after, you can give it within a space of another 30 minutes within to 24 hours. And IV fluids to resuscitate the woman if need be, together with all these IV medications you are giving. The other thing would be the E. That is examination of the genital tract. So after you've done all these things, there should be someone who is also finding other causes of the PPH apart from the atony. So they have to examine the genital tract. They need to expel clots and all that to be able to ascertain the fact that it's not retained product, or it is not trauma, or it's not tissue that is causing the PPH. If you do all these things and it fails, then we move to refractory. That is a refractory PPH. So for the refractory PPH, I think I already mentioned some in the hemostasis. In theater, Most of these are done in theater. You can do a balloon tamponade, condom tamponade. Okay, so these are examples of the balloon. The commonest ones we use here is the male condom attached to the Foley's catheter. This an image of it. You would see it over here. There are others which we commonly use here, but the main essence is to cause myo tamponade. And this is by manual compression. I think I already mentioned it whilst you're on your way to theater. And this is the non-pneumatic anti-shock garment. It's used in some facilities where they don't have theater to be able to manage some of the refractory responses to PPH, and then in a way to transport the patient to a higher facility, whether a secondary or tertiary facility, so that the patient does not go into severe hypovolemic shock and die. This is the garment that is usually given to the patient. And the essence of it is to slow or reduce the blood flow, reverse the blood flow to vital organs in order to decrease the bleeding. There are some indications that we can look at later. So other compressive methods in theater, a B-linge can be done. There are other types, other compressive methods to that. The Heyman, the Cho B-linge can be done. These are sutures that are put along the incision sites anteriorly over the fundus to the posterior sites, and then they are tied, and then they are compressed in between two hands to ensure that the uterus, the anterior and the posterior walls oppose each other and causes the myotamponade action. There's also uterine artery ligation, which is done by ligating the uterine arteries. We also have the bilateral internal artery ligation. All these are surgical procedures that can be done to reduce the bleeding. When all these conventional methods, these refractory methods we mentioned fail, there's a place for peripartum hysterectomy, and there are indications for them, of course. And they also come with their complications, blood transfusion issues, and then coagulopathies, and then sometimes they can come with also infections. Let's look at retained products, the next T. So with retained products, you need to really assess, first of all, if the woman, let's say the woman is referred to you or the woman is delivered at your facility and she's bleeding, you've massaged the uterus and all that, she's still bleeding. One of the things, even per your initial assessment, that you want to find out is the placenta, about the placenta, whether it was delivered wholly or not. So if the placenta is not delivered, you need to treat for whole retained placenta. So this is an emergency, something you have to do in theater. Before you go to the theater, you can give oxytocins. You can attempt to do controlled cord traction again. And then sometimes you can inject syntocinon through the intra-umbilical vein. If the whole placenta retains, then you go to theater, and then you do manual removal of placenta under analgesia and give antibiotics. If the placenta is incomplete, treat for retained placenta fragments by sometimes removing the placenta in piecemeal. All these are also, and then gentle curettage and aspiration. All these should also be done in theater with good anesthesia. If the bleeding still persists, treat as uterine atony. So this evacuation of the placenta. So it's usually commonly done in theater, like I already mentioned. So under aseptic conditions, you wear gloves, and then you insert your fingers into the uterus, through the vagina, along the length of the umbilical cord. And then you find a point of detachment of the placenta and insert the edge of your finger in between the placenta and then the uterine wall, and try to bring out the placenta, or try to shed off the placenta gently till you have a complete placenta in your hand, and then you gently bring it out. And after that, whilst you're in theater, you can inspect for tears and lacerations and suture if need be. Cervical laceration, that's for the other T, the tears. So with that one, they commonly occur at 3 o'clock and 9 o'clock because the uterine vessels insert at those positions. It's usually made, the diagnosis will usually be made after you ruled out uterine atony, and then the woman or the uterus is well contracted and the woman is still bleeding profusely. So you need to take the woman to theater, examine under anesthesia when she's relaxed, and then explore, look for areas of tears or lacerations and repair. Then the woman is put on antibiotics as well. Broad ligament hematoma, this would also be done in theater evacuation. Uterine rupture could be incomplete or complete uterine rupture, which should be repaired in theater. This is the last T, that's a thrombin. And we can have congenital, I already mentioned congenital and then acquired. The clinical manifestation is varied based on the cause of the coagulopathy, and the management can be medical. Usually, if it's also surgical, it has to be managed appropriately. So I think I already mentioned the management of the coagulopathy. Uterine inversion is one of the causes of PPH. It could be acute or chronic. It's quite fatal if it's not recognized early and treated appropriately. And when it's, I brought some pictures that will help us. So you have a collapse of the fundus into the uterine cavity, and the woman will start bleeding profusely. It has to be corrected. Usually, we have mechanical correction, that is manual reduction, and then in theater, you can do hydrostatic reduction and also some surgical reductions. How do we prevent postpartum hemorrhage? So the prevention would be both antenatally and intrapartum. Antenatally, once the woman starts attending the antenatal clinic, her health in totality should be looked at. She should be educated, her hematinics should be taken, because it's been shown that anemia is one of the risk factors for postpartum hemorrhage. Once a woman's blood is low, you just need a little amount of blood to be lost for her to start being hemodynamically unstable. So her optimization of her blood, of her HB, nutrition-wise, she should be counseled on being the hematinics. And then high-risk patient should be picked up and then counseled and monitored regularly so that the complications of PPH that is normally that will usually set in would be reduced because they'll be picked up early and managed appropriately. And then blood grouping, women that come to the ANC should have their blood grouping done at any time so that they already know their blood group, which I think is done in most of our ANCs. Placental location should be identified, very importantly. And then women with morbid adherent placenta should be referred to see an obstetrician so that they'll be managed appropriately. Intrapartum, the active management of the third stage of labor, which includes controlled cord traction, massaging of the uterus, and then the oxytocin should be done, should be ensured, and should be make sure that it is done so that it will reduce. It's been shown that it reduces about 60% of primary postpartum hemorrhage. Also, judicious use of syntocinon, because the abuse of it has been shown to cause sometimes precipitous labor and then also causes PPH because it affects the uterus ability to contract. Timely episiotomy to be able to ensure that women don't have unnecessary tears where they are not supposed to have. And also minimizing and preventing the delays will contribute massively to the reduction of PPH. These are some recommendations that FIGO has made over the years. It's grouped them into recognizing early every patient, every hemorrhage, every unit. So it's mainly about recognizing the high risk, most of them are even antenatal, high risk patients, checking to see their ANC medications, whether they are on it, and then intrapartum, also managing the active stage of labor appropriately. And then once there is hemorrhage, every hemorrhage, the appropriate response, the immediate diagnosis of the event of the PPH should be recognized so that the woman can be managed appropriately, and also bringing support groups, families, especially if you find the high-risk patient, bringing them on board so that they will be able to help with the preventive measures to prevent PPH. So this actually a recommendation that was made in 2020, and that's what I mentioned, the primary care bundle. That was a systemic way of approach, which now has been modified by the emotive, which is doing all these management at a go within a space of 15 minutes. And it's actually been shown that the outcomes have been significantly improved with using the emotive. I've mentioned most of these already. So complication of PPH, we can have early and late. Early complications, the woman can bleed torrentially, which will lead to hypovolemic shock, heart failure. You can have cerebral ischemia, renal failure, acute and later chronic, and then she can die suddenly also. Late anemia with all its complications, transfusion-related issues that can arise, puerperal sepsis, and also she can have DVT and Sheehan syndrome, which is from the infection of the anterior pituitary. So to conclude, PPH is a very serious event, actually. Others say that it's not a diagnosis, it's an event, and it's life-threatening. The values, the figures around the world are quite alarming. And if we're able to stimulate a lot more training of people and to encourage hospitals to come up with protocols that will be able to manage PPH effectively, and early recognition of the disease and then its complications, I think that it can help. And also making available some of the drugs, because most of the drugs are quite low cost and they can be used to manage the PPH effectively. And then when women are in labor, also active management of the third stage of labor and monitoring of their vitals and monitoring of their signs, and to measure the blood loss accurately to be able to make a good assessment of the PPH and manage it appropriately, has been shown to be very effective. Thank you. These are my references. Thank you very much.
Great. Thank you very much, Dr. Dieu-Donnee. An excellent one. I've learned a lot myself. I'm sure the over 280 participants on the call have also learned a lot. Just before we take the questions and read what is in the chat box, I would want our consultant, Dr. Howard, to make any inputs that she may have, and then we can start the questions. So, Dr. Howard.
Good afternoon to everybody. Thank you for the opportunity. And I'm very glad that we are talking about such a sensitive topic on a day, a very important day as today. Today is for women. And it's a good way to start by talking about primary postpartum hemorrhage, which renders homes, it takes homes into very difficult places when a mother is lost. And I'm happy that a lot of people are on this call to hear all the things that have been said about primary postpartum hemorrhage. It is very common. And I was on a call a few weeks ago and I was talking about this emotive thing. It's something that we do, but the ease at the front and the back are always our problem. Early detection and then the escalation. If you're able to detect the PPH early, and you put in all the measures that you already know of, and then notice when the woman is not doing well early so that you can escalate, move from the small facility to the next. If you are in a big facility, don't waste time in the labor ward struggling with the woman to stop the bleeding there. You escalate to the theater. Then we can stop a lot more of this mortality. We have PPH still as the #1 cause of maternal mortality for us in the country. And there is a lot we can do to change the narrative. I want us to take home the message that in our small corners where we do the deliveries, when you go back to work on Monday or tomorrow, for those of us who will be on weekend duty, check your corner and see whether you can actually solve a PPH at that time. Do you have the IV fluids there? Do you have normal saline? Do you have cannulas, white ball cannulas, green and ash cannulas? Are they there? Do you have oxytocin? Is your oxytocin, is it in the fridge or is lying on the table? Because if it's on the table, it's not going to work out. You need it to be in some cold chain. Do you have misoprostol? Do you have tranexamic acid? and then the rest will just come easy, because the first is for you to know that the woman is bleeding. And Dr. Donnee has taken us through a very beautiful, elaborate presentation for us to be able to pick up PPH early and then do the things that we have to do. Thank you very much, Dominic, for this opportunity.
Excellent. Thank you so much. Like I indicated, we are getting very good responses, both in the chat box and direct messages, saying how wonderful this presentation has been. Actually, I must admit that I learned a lot myself. It's been a long while since I've read and listened to a presentation on postpartum hemorrhage, primary postpartum hemorrhage. So it brings a lot of updates to me, and I'm sure a lot of us as well on the call. So the good news is that this is being recorded, and as we said, we are putting it up on the YouTube channel. And then I've just put a link in the chat box. So if all of us can go to the chat box now, you realize that there's a link in there. Just click on that link, and then you'll be able to evaluate what we have just done. It takes you less than 5 minutes to do that. And then as well, those who want the presentation slides, in addition to the videos that will be put on the YouTube, after you are done with the evaluation, the next is just a single box that asks you to put in your email address, and then we'll send the slides over to you. So if all of us can just check in the chat box and you see this link in there, click on it and provide us with this, and then I'm able to send the slides over to you. Someone is just asking for it, and so I'll put it back there. I've just done that. So if you can click on the link, and then you can provide us with your responses as well, and then put in your email address, and then we'll have the slides sent over to you. I must also say that Dr. Donnee has done excellently within the time period. When I saw 40 plus slides, I was afraid we won't be able to do it in the 1 hour like we've built. The good thing is that we started, because of the network issues, we started about 15 minutes after 3, but we'll be able to do this in less than 30 minutes because you finished at about 3:42, which is good. So we would take your comments. If you have any question, kindly electronically raise up your hand. I will unmute you, and then you can go ahead and ask your question. Please, those of us putting the emails in the chat box, that is not what I meant. So if you look in the chat box, rather, there's a link I've put in there now. Just click on the link. And then when you click on that link, when you provide the responses, the very last question in that link is provide your email address if you want the slides. And then we'll be able to send the slides over to you. Because at the end of this presentation, I will not be able to have the chat box to have the email addresses. But this link will still be available so that I can be able to fish out the email addresses and send the PowerPoint slides to you. So kindly follow what I've just said. If you all go back to the chat box, you realize that there's a link I've put in there now. And if you need the slides, just click on that link, provide the responses, and then provide your email address, and then we can send the slides over to you. I've resent the link severally, and I've resent it just now. Please look again in the chat box. So if anyone has any question, kindly electronically raise up your hand, and then I will mute you to ask. Or if you have a suggestion and edit anything to enhance this program and make it better for all of us, please, the time is now. We have about 5 minutes to the top of the hour. So if you do, kindly electronically raise up your hand. Okay, so I don't see any hand up. I would go into the chat box to read the comments there and then see if we can address them. Yeah, so Dinah has her hand up. Dinah, please go ahead. I've asked you to unmute yourself. Kindly unmute yourself and go ahead.
Yes, good afternoon. Please, I'm speaking from WA. I want to find out, will the placenta be ahead? Like if you deliver a case and you realize that placenta is too attached, or the placenta tissues are too attached to the uterus, what do you do after massaging, giving your oxytocin, giving your tranexamic acid, and certain uplines giving infusions? What should you do again? Because this topic, it makes me so emotional that I have to lose a woman through that. So I want to find out what should we have done, because we call for help. doctor came, but unfortunately, within some 2 hours, the woman passed on.
Yeah, sorry to hear about that difficulty. So, Dr. Howard, please go ahead.
Yeah, so I'm really sorry for your very negative experience, and I'm sure you gave her all your best. Now, when the placenta is very firmly attached to the uterus, and your conventional controlled cord traction is not relieving the placenta to come out, allow it to be. Clamp the cord like you have done already, and refer if you are not in a facility that can go to theater. The danger is for you to force to remove it, and now parts of it will open, yet the whole thing didn't come. And it's like opening a pipe that cannot close. The valve cannot close. You see, when you have a pipe in your house and it crosses thread and you are trying to close, it won't close. So parts of the placenta has come, the rest won't come. That is very dangerous, and the woman can bleed torrentially. And it's really unfortunate you lost your patient. So once you try your control cord traction, you're giving oxytocin once or twice, it's not happening, you just leave it as it is. Don't force it and take it. And that's why we encourage that manual removal of placenta should be done in theater, so that when you put your hand inside and realize that this is a morbidly adhered placenta, immediately you are opening up to do a laparotomy. So if you go and do your manual removals, you are fond of doing your manual removals in the labor ward, and you go and meet this kind of placenta there, and you open and half of it comes out, then the woman is going to bleed torrentially. So if you have resistance, it's always better. When they are morbidly adhered, they usually will not bleed. But it's when parts of it open, then the bleeding becomes heavy. And if you are not lucky, you lose it. But always remember your resuscitation. So as she's bleeding, you are pumping your IV fluids down. You are doing all the other things that Dr. Donnee mentioned, the bimanual compression of the aorta, all that will slow down the blood flow whilst you prepare and move to a bigger facility or theater. Thank you.
Thank you, Dr. Howard. And that's one of the reasons for having this meeting, also as well to establish some form of mentor-mentee relation. You realize in the next couple of months, in May, we'll be having in-person trainings as well for those of us in the upper regions. They also create some form of local network, so that then if you are in such a facility, instead of you just think you have gotten to the limit and you are going to refer the person, there may be some life-saving interventions that can be passed on to you on the phone. So one of the good things about the maternity service agenda as well is not only the fact that it's open as a webinar for all of us, we'll be having practical sessions as well, which will establish some form of a chain of referral, a mentor-mentee relationship as well. So I'll quickly take a couple of the comments in the chat box, and then we see if we have some few other people to talk, and then we can end the session. Because we started about 15 minutes after 4, it's only good to allow for about 15 minutes for the discussion, if so be, because this is a very important topic, like all of us know. The first one is from TechnoSpark. Unfortunately, the person didn't use the name. We advise that when you log in, and it's good to use your name so that we can address you by name. He's asking, how can I record the meeting because my network is bad? Okay, so this is being recorded. And like Dr. Hartfield mentioned, it will be put up on the Ghana Medical Help YouTube channel for you. The slides, like I've said, will be made available when you fill in that link that I've put in the chat box with your email address. Then Margaret Batuta mentioned that some of our pregnant women these days do take this local oxytocin when they are in labor. They usually come with strong uterine contractions without relaxing, even if the person is 1 cm dilated. And you can record contractions of about 2 to 3 in 10 minutes, lasting above the 30 to 45 seconds. And the outcome of progress of labor is not always encouraging. I think she's probably passing a comment with regards to the use of oxytocin by way of either self-medication or from a lower periphery before the patient comes in. Dr. Donnee, Dr. Howard, do you have any take on that?
Okay, so for patients like that come in, it means that they are at risk of getting PPH, precipitous labor, and PPH. So when they come and the contractions are very strong, you can sedate them. You can give them IV petidine. IM petidine, promethazine, and if the contractions are still not relieving or becoming normal, you can then give sometimes some tocolytics, so magnesium sulfate, salbutamol, and then refer to the nearest facility, a bigger facility.
Great. Thank you so much, Dr. Donnee. So Siva says all the way, is zooming in all the way from Swedro region. I think that's in the central region. I'm Hannah, a midwife under the Gomoa Central District, currently with a CHIPS compound. I saw this and decided to join. I've even shared it on our various pages. Yeah, thank you, Hannah. Since I can barely, how do I get the hard copy? Yeah, so Hannah, we don't have hard copies to send out, but we have soft copies. And the link I've put in as well. Just click on it, provide a survey, provide your email address, and you would have the PowerPoint slide sent to you. If you also need the video, just log on to YouTube, put in Ghana Medical Help, and you have the video there for you to watch what we have just done. Thank you so much for joining in from the central region. Dr. Salam Abdul Kader says, thanks, boss, for the comprehensive presentation. Aside blood products, is there any recommended pharmacological treatment for PPH secondary to DIC, disseminated intravascular coagulation? So Dr. Dieu-Donnee and Dr. Howard, any response to that? PPH from a DIC, any other pharmacological treatment other than the blood products given?
From literature, it's mainly blood product and tranexamic acid. Also, the activated recombinant factor 7 has been shown to help in the management of coagulopathy as a cause of PPH, which of course is not common in our setting. But tranexamic acid, the blood products, really help.
Excellent, excellent. So we at the medical part of it, we've had to manage a couple of cases of AKI following DIC in pregnant women, and a couple of times the approach is usually a bit conservative, and sometimes we may have to go in for dialysis if there's an indication for it as well. Most of these management, especially, I think, is encouraged where there's a multidisciplinary team approach to the management. And so in the lower peripheries, if you suspect this, it's usually strongly advised that you probably refer to a center that can have a multidisciplinary team approach, and so be able to help the lady or the pregnant woman survive. Yeah, then Phyllis does put in, good afternoon, doctor. Please, can I have the recorded version? I received the link late. Yeah, so just like I said, click on the link. We'll send the slides to you, the recorded version available in YouTube. Citizen Thomas says, great submission. Thank you, Citizen Thomas. AC says, please, I didn't hear the use of misoprostol in the management. Please, is it no longer in use? Dr. Donnee.
It's in use, please. I think I mentioned it along between 800 to 1,000 micrograms.
Fantastic. Yeah, so there you go. Then Lawrence Awafu says, can you please throw more light on the use of oxytocin and PPH?
Okay, so
yeah, so doctor, yeah.
Yes, it plays several roles. Immediately the baby is born, within a minute of delivery of the baby, once you are sure there's no other baby inside, you give the first dose of your oxytocin. So if you are doing IM, you give 10 units. If you are giving it IV, like we do when we are in theater, then they will give 5 units. And that helps in the delivery of the placenta. Now,
great. All right. Thank you, Dr. Awa. Yeah, then Priscilla does put in, we are grateful for the presentation. So obviously, thanks to the leading team for today. Excellent job. Scroll down. Dr. Salam did mention, is it recommended to give long-acting oxytocin analogs such as carbetocin prophylactically in high-risk cases for PPH? So that's his question. The use of long-acting oxytocin analogs like the carbetocin for prophylaxis in high-risk cases for PPH. Dr. Howard, Dr. Donnee, any response to that?
Yeah, so we give the oxytocin for prophylaxis, but for carbetocin, we use it when we make a diagnosis of the PPH. And for now, we don't even have it in all facilities around. We are encouraging our service, Ministry of Health, Ghana Health Service, CHAG, to get these drugs because it's even much more easier to keep carbetocin compared to oxytocin. Oxytocin, you need a fridge, carbetocin, you don't. So though it's a little more expensive, but it is better that we have that. But we don't use it as prophylaxis. We use it in management. So prophylaxis against, we use the oxytocin and also use the misoprostol that you can give between 800 and 1,000. That is 4 to 5 tablets directly. And that will help prevent the PPH.
Okay, great. Thank you, Dr. Howard. So I think some few other comments. Thanks so much, Doc. I've learned a lot. God bless you. God bless you too. And thanks to Dr. Howard, thanks to Dr. Donnee for an excellent work. Candida says a very big thank you to the organizers. God bless you. So obviously, I think a lot of people are appreciative for the efforts, Dr. Donnee, Dr. Howard, and all those who put this presentation together. LV1 says, I've really learned a lot. Thank you all. Yeah. Haruna did mention that Dr. Donnee, you are very fast. Haruna, we have the recording available on the YouTube. I think we can listen to that over and over again. But well noted. Definitely, we'll slow down the pace. Bernard, please, how do you do the aortic compression? Yeah. So this is one of the things that we did mention regards the practical training bit of it. This will also be demonstrated when we have in-person practical sessions. Then Phyllis says, can I have the link to join subsequent presentation? Fantastic. Yeah. So Phyllis, on a weekly basis, the same platform that you did get this link, it will be put up on all those platforms as well, so that then you can easily have that sent over to you. So we encourage that those on the midwives and the doctors in obstetrics and gynecology platforms, when you get the link, you can share it on all those platforms. Comfort says the network was bad, and yeah, so with your email address in the link I've provided, we should be able to send you the PowerPoint presentation. The other one, I think from Candice, how do I identify a client with occult bleeding? Maybe I'll just take a couple of, maybe about 3 or 4 questions, and then we can address them. So a client with occult bleeding, how to identify it. The second one is asking whether when the placenta is adhered to the uterus, an ultrasound scan can detect it. And yeah, so those are the 2 for now. Dr. Howard, Dr. Donnee, will you want to take those 2? Adherent placenta being detected by the ultrasound, and then the other one about occult bleeding.
Okay, so the occult bleeding, you pick up, and Dr. Donnee addressed it during the presentation. So you are not seeing the woman bleeding actively outside, but something has happened within the abdomen, and she's losing blood into the abdomen. So you will pick up the signs and symptoms of blood loss. So your pulse rate is going high, your respiratory rate is going high, your blood pressure is dropping. And then the woman is generally restless. You are seeing signs, pallor, and maybe if you are not picking it even up early, she's showing signs of shock. Then you should be thinking that something is going on in the abdomen. I think some distension of the abdomen. The abdomen is tender, unduly tender. You see, even if it is after a delivery, you shouldn't have so much tenderness of the abdomen. So when you see all these things, then you should be thinking that some bleeding is ongoing. It's just that it's not coming outside. and you would have to take measures to find it and then deal with it. And a typical way is when a woman who has had a previous cesarean section ends up delivering vaginally. So she successfully brings the baby out, but then there was a rupture that was missed, and then she bleeds into the abdomen. Sometimes it doesn't even come out, and then you don't see it. So we can pick occult bleeding. And for the morbidly adhered placenta, yes, there is a criteria of picking it up on ultrasound examination, especially if you're using a good ultrasound scan that has all the features of doing Doppler and all that. You'll be able to tell that this placenta's vessels have gone beyond where it's supposed to be and within the myometrium or even beyond, and has crossed into the serosa. So there is a way of picking it up. And if your sonographer is very good, they have the ability to tell you that this one, I suspect, is a morbidly adhered placenta. But if you have a woman who has had a previous surgery, so previous cesarean section, and she comes back with a placenta previa, now the placenta is in low lying, then you should be worried that this placenta is morbidly adhered because the scar may be holding onto the placenta. Then you ask for somebody who is experienced to do the scan for you. Thank you.
Great. Thank you so much. So again, a couple of the questions in the chat box, or asking for the link, and I've put it there twice just about now. So those who have not been able to click on it to provide their email addresses, you could kindly do that, and then we have it. And someone asking about the YouTube handle, that's Ghana Medical Help, like I did mention. Yeah, so I think we may not be able to pick up the rest of the comments because we've gone way past the 4 o'clock. However, we'll give the can this iPhone, I see your hand is up, if you can unmute yourself and ask your question, and then we can conclude for today. Thank you so much. Can this iPhone, please go ahead. You can unmute yourself.
Okay, so my question has been answered.
All right, fantastic. So I guess it's a legacy hand. I'll just go ahead for you. Yeah, so thanks so much to everyone for coming today and for joining this presentation. We are grateful that you made time on your Friday evening to join us. We are also super excited and thankful and grateful to Dr. Dieu-Donnee and Dr. Howard for putting up this brilliant presentation, and more especially for addressing a couple of the questions that people did put up. So just bookmark your calendars, make note of it, set a reminder, Friday, 3 p.m. every week. If you want to learn a thing for just 1 hour, you can join us on this same call. Friday, same call, same time. Use the same link. The same link is not going to change. So even if you don't get the advert and you are available on a Friday, just click on the same link like you joined today, and you realize that you are good to go. You'll be on. So thank you so much. I want to especially thank Dr. Dieu-Donnee for doing the presentation. I want to thank my boss and legendary sister, Dr. Howard, for making time this Friday to join us to throw beautiful insights into primary postpartum hemorrhage. I want to especially thank Dr. Hartfield Kelly for coming up with the concept of Ghana Medical Help, and of course, driving the change all the way from Canada, and to Angela for putting up the survey, and the rest of the maternity service agenda team. We are so much grateful for making this possible. I think the first day has been a success. Sorry and apologies to you that we've had to start just a little late because of the network challenges. And we are grateful that you still stayed on. We had an average of about 280 participants, which is one of our highest we've had in our presentations. So it just shows that a lot of us would want to learn about maternity, learn about how to save the lives of pregnant women and newborn. And especially on a day like International Women's Day, want to say a happy International Women's Day to all females. And we admire you for all that you do. God bless you for all that you do. So till we come your way next week, same time, same place, same link, same code and password. We'll see you on Friday. God bless all of us. And thank you so much for joining us. So the link is what I've put in the chat box once again. So those who probably did not get it. Just for the last time before we sign out, you can just click on the link that is there now, and then